Welcome to our session on the principles of pharmacology, specifically focusing on reproductive health. Today we will explore the physiological and pharmacological aspects of how certain medications interact with the human body. Understanding these foundations is essential for clinical practice and ensuring patient safety in specialized care. In this section, we transition to a specific and highly relevant area of men's health: drugs used for erectile dysfunction. This topic bridges the gap between vascular physiology and clinical pharmacology. We will examine how targeted therapies can address common reproductive health challenges and improve the quality of life for many patients. Erectile dysfunction, often called ED or impotence, is defined as the persistent difficulty in achieving or maintaining an erection firm enough for satisfactory sexual activity. While occasional issues are normal, frequent occurrences can be distressing. Statistically, it affects over half of men between 40 and 70, making it a common medical concern. Understanding erections requires looking at three distinct triggers. Psychogenic erections are driven by the mind through thoughts or sensory cues. Reflexogenic erections result from direct physical touch via a local reflex arc. Lastly, nocturnal erections occur involuntarily during sleep, acting as a natural maintenance mechanism to ensure healthy tissue oxygenation and function. An erection is a sophisticated mind and body team effort. It is fundamentally a neurovascular event, meaning it relies on a precise coordination between nerve signals and blood flow. When these systems work together, the penis becomes enlarged and firm. This process is the foundation for understanding how pharmacological interventions actually work. The biological process begins with sexual stimulation, triggered by things seen, felt, smelled, heard, or thought. The brain signals the parasympathetic nerves to release nitric oxide and acetylcholine to the penis. Nitric oxide then activates an enzyme called guanylate cyclase to produce a secondary messenger called cyclic guanosine monophosphate, or cGMP. This chemical cascade triggers smooth muscle relaxation, allowing blood to flow in and fill the tissues of the corpora cavernosa, resulting in penis engorgement. To summarize the process, stimulation leads to nitric oxide release, which produces cGMP to relax muscles. As arteries dilate, blood rushes into the spongy chambers. These expanding chambers then press against veins, trapping the blood to maintain firmness. The process reverses or reaches detumescence when stimulation ends and the muscles contract again. Physical causes of ED are diverse. Cardiovascular diseases like high blood pressure and metabolic issues like diabetes often damage blood vessels and nerves. Hormonal imbalances, neurological disorders, and certain medications for depression or blood pressure also play a role. Even lifestyle factors like smoking and alcohol can significantly impair the necessary vascular responses. Psychological factors are equally important. Depression, anxiety, and high stress levels can disrupt the neural signaling required for arousal. Relationship conflicts and performance anxiety often create a cycle of inhibition. Additionally, modern issues like excessive pornography use can lead to unrealistic expectations and digital fatigue, further complicating the physiological response to real-world stimuli. When evaluating a patient, we must consider both physical and psychological roots. From atherosclerosis and hormonal imbalances to stress and trauma, the causes are often multifaceted. As future healthcare professionals, you should be prepared to counsel patients on how these varied factors, ranging from medication side effects to mental health, contribute to their overall condition. Several risk factors increase the likelihood of ED. Age is a primary factor, but chronic medical conditions like kidney disease and diabetes are major contributors. Lifestyle choices, including obesity and lack of exercise, also elevate risk. Understanding these helps in identifying patients who may benefit most from early intervention and targeted lifestyle counseling. Treatment always starts with addressing the underlying cause. Non-pharmacological approaches are often the first line of defense. We encourage lifestyle modifications such as quitting smoking, reducing alcohol intake, and maintaining a healthy diet and exercise routine. Stress management and couples counseling are also vital for addressing the psychological components of the condition. When lifestyle changes aren't enough, we turn to PDE5 inhibitors like sildenafil and tadalafil. These are first-line oral treatments taken shortly before activity. Crucially, they are absolutely contraindicated for patients taking nitrates, such as nitroglycerin, because the combination can cause a life-threatening drop in blood pressure. Safety and screening are paramount here. PDE5 inhibitors work by blocking PDE5, the enzyme that breaks down cGMP. By preventing this breakdown, the medication prolongs lifetime of cGMP, therefore prolonging muscle relaxation and enhances blood flow. It is important to remember that these drugs do not cause an erection automatically. They still require the natural sexual stimulation to initiate the nitric oxide release that starts the process. If oral medications are not suitable, alternative pharmacological methods exist. Intracavernosal injections involve administering vasodilators such as alprostadil directly into the penile tissue. Another option is an intraurethral suppository. For patients with laboratory-confirmed deficiencies, testosterone replacement therapy may be used. These options provide targeted delivery when systemic oral treatments are ineffective or unsafe for the patient. That concludes our overview of the erectile dysfunction. We have covered the biological mechanisms, the causes, and the treatment pathways available today. Thank you for your attention, and I hope this provides a clear foundation for your future clinical practice and patient care.